Hi, everybody. This is Mark Newman from Precision Analytical, the makers of the Dutch test. And I've got some data for you that I want to share to help illuminate this issue that continues to be confusing for providers because we get different messages depending on who we're learning from. And I'm going to call this the transdermal testing controversy, which simply says this is a known fact that when you take, just call them normal doses of progesterone or testosterone or estradiol, the increases you see in saliva or dried blood spot greatly exceed what you see in serum or urine. And we want to make sense of that, right? So I've got some data to share with you about testosterone in this video that's going to help. Here's some data for you to consider. First thing we want to say is I've made some videos that have to do with progesterone data. What I'm always teaching people is you cannot draw conclusions from progesterone data and extrapolate them to testosterone. You can see this combination of studies in the literature. The green data is progesterone. Does it ever climb up into the luteal range for progesterone? Not at doses that are typically used, but testosterone does. It goes up in a linear dose-dependent manner. So lesson number one, don't treat progesterone and testosterone the same. You've got to dig through the data independently. But the point of this video is to look at this dichotomy that we're talking about. On the right, you can see published data from serum testosterone when we're looking at transdermal gels, and you can see on the left salivary data. Now, if we just compare the same dose, 50 milligrams, totally different message, right? It's linear and dose dependent if you look at enough data, either way, but it's a really different message, right? Saliva seems to say 50 milligrams is a ton, way above the male normal range, too much testosterone. Serum says, nah, that's about right, right? So we want to take that data, we want to ask this question. This is a critical question. Do any studies show clinical changes from transdermal testosterone gels that exceed the predictions you would make from the changes in serum or in urine, right? So if what you see clinically exceeds what you see in serum, then it's a hint that, hey, that saliva data might have something to teach us, right? Here's some published data. This is not peer-reviewed, but data that might be helpful from saliva and dried blood spot that says, hey, if we're looking at men taking less than 50 milligrams, so here are the two groups less than 50 milligrams, we're getting saliva values on average around 600 and blood spot around 2000. Now the reference range is 56 to 221, which means that is, according to saliva, a ton of hormone, right? Dried blood spot gives you something similar, almost twice the high end of the reference range while not using 50 milligrams. So now we can ask this question, and I've presented this data, so I'm gonna go quickly through this into the data I really want you to see, but we can look at 50 milligrams and we can say, hey, if that's a lot of testosterone, serum would say otherwise, urine would say otherwise, but if it is, let's look at erythrocytosis. Erythrocytosis should be going way up if it's too much testosterone. You can look at that study, which says that it doesn't. LH should plummet if you're really taking a ton of testosterone with 50 milligrams, but it doesn't. It's a modest decrease. Finkelstein or Finkelstein, not sure how you say his name, but that's a really interesting study where they looked at 50 milligrams and it worked, 100 milligrams and it worked, 25 milligrams, they barely got a difference. And then when they went below that to 12.5 milligrams, guess what? The study failed, right? Which says that there's an alignment there between the data that you're seeing in serum and the clinical data that you're seeing, because it takes 25 or 50 milligrams to get your serum testosterone to really increase very much. Here's the key point, and I will put this out to anyone as a challenge because we need to be considering all of the data. Can you find a study where the clinical change what would be predicted based on serum values looking at a testosterone cream or gel? I haven't found any studies to date that show that that might be true. Now, let's hone in on the data I really wanted to get to. I'm going to hone in on 5 to 20 milligrams, which says, hey, if I'm at 5 to 50 to 20 milligrams, that's more than the male range. And I'm at around 1200 in dried blood spot, which is the top end of the range. Now, we could have a debate right now about if that was true, if that was truly representative of tissue, is that too much testosterone for a man? And we could have a debate about that, right? But if we're even in the ballpark of too much testosterone for a man, I ask you this. And this is the question I ask the literature is, what happens when you give those doses to a female patient? right? Because if you look at serum or urine, they're going to imply that's an insufficient dose for a man. And if you gave it to a woman, she might not have a whole bunch of symptoms, right? So I went and looked and said, find every paper you can where they're using 5 to 20 milligrams of a cream or gel of testosterone. And what you find is, again, saliva and blood spot imply that that dose range is maybe too much for a man, yet there are no symptoms of elevated testosterone in women who are using these ranges of dosages. And these studies are doing fairly sophisticated assessments of high levels of testosterone. Some of them are even looking at things like clitoral enlargement, voice deepening, abnormal hair loss, abnormal hair growth, the types of things that you'd expect to see if it was too much testosterone. And in these studies where women are using 5 and 10 and 15 milligrams a day, they were seeing some clinical improvement in their symptoms of low testosterone. But again, the key point, they weren't seeing symptoms of too much testosterone. So that tells you something I think pretty important. So you can draw your own conclusions. Serum or urine imply that the skin absorbs about 10% testosterone. Saliva and dried blood spot imply that the skin absorbs closer to 100%. Saliva and dried blood spot imply that 5 to 10 milligrams is a monster female dose of testosterone, enough to cause significant symptoms, but that's not what we find in the data. And I just want to make it really clear, I'm not suggesting that women need 10 milligrams of testosterone. My only point is, if they take 10 milligrams in these studies, it should be enough to have the type of changes you'd expect in like a transsexual hormone replacement sort of situation where you're getting massive increases in the types of symptoms you see in a woman who has too much testosterone. And again, from all the studies that have been done, there aren't lots of them, but we've got around 8, and I think that's comprehensive from what I've seen in digging into the literature. And again, if you run into studies that say otherwise, that say, hey, here's a study where a woman's taking 5 milligrams of testosterone and we got massive increases in hair in places we don't want it, those types of symptoms, that would be super relevant for this debate. But as of today, I don't see any of that data, and I think that's pretty relevant in our understanding of building a model in which we understand which lab values in this scenario coincides with the type of clinical changes that you see. Pretty interesting data. Let me know what you think. If you have any questions, reach out. We'd love to continue this conversation so that we can all understand better how to treat our patients and test our patients that are on hormone replacement therapy, and watch the other videos for some really interesting data on the similar topic.